Good evening, everybody, and welcome to the primary care session. Today we're going to be talking about careers in primary care with allied health professions. We've got physiotherapists, we have got podiatrists, occupational therapists, speech and language therapists, dietitian and paramedics. So please use your chat boxes today because the panel will be able to take questions through the chat box, and we'll have a 15-minute session at the end where we can talk about it. So my name's Amanda Hensman-Crook. I am a consultant MSK physiotherapist in primary care in my clinical role, but I'm also Health Education England's Allied Health Professions National Clinical Fellow, and I work for Health Education England in primary care with these new roles moving into primary care now. So what we're going to be talking about are the new roles moving into primary care, but we're also going to talk about potential roles moving into primary care as well. So please can I have the slide? We're just waiting for a slide there. That's lovely. Thank you very much. So hopefully you can all see that. So what the slide is showing is a career pathway from undergraduate level through to advanced practice in primary care. So it gives you an idea of how you might be able to get to these roles in primary care. So the two roles that are moving into primary care, first contact practitioner roles and advanced practice roles. So when you are as an undergraduate, there's now exposure to primary care placement. So it's really important that you get used to working within primary care because it's a completely different way of being other than secondary care and community care. Once you're qualified and registered, you then move into postgraduate practice. So I would recommend everybody to have a really broad base of knowledge if you're moving into primary care, because it's not just about the role that you're doing. It's also about having that really good knowledge of all the different care pathways across the system and about how to get into those different care pathways when referring in. Then once you've qualified for a couple of years and you've learnt your craft, at the beginning, when you first qualify, you're a novice practitioner, so you're just learning your craft. So you're developing how you put all that knowledge into practice and get used to being a clinician. And then over the next 3 years, when you specialise and get used to bringing that knowledge into practice, then you start on the primary care training pathway. You can train to work into primary care either by a taught master's module at a university, or you can go via a portfolio route. Many of you may have known, if you're clinicians already out there, that we have landed the MSK roadmap for first contact practitioners and advanced practitioners in primary care. That roadmap is actually generic. If you take out the framework and then you pop in a paramedic or an OT or a dietitian, podiatrist, then that roadmap is exactly the same, but with specific knowledge skills around the professions that I've just listed now, so that the training's exactly the same, at the same level of practice, at master's level for all of the professions, but you follow the same route, you have the same governance and the same supervision structure. So the taught route is really a module that has both stages of practice in it. So the first stage in a portfolio route would be when you're developing your academic knowledge to level 7, which is a master's level of practice. And then once you've done that, you then go into primary care once you've done stage 1, and then you complete the training that makes sure that you're verified to level 7. It means that you can put your academic knowledge to practice and you're signed off by your supervisor. That's the first contact practice, and then you can continue on to advanced practice afterwards. So first contact practice is when clinically, in your clinical practice, you're working at master's level. But advanced practitioners work across all 4 parts of practice, which is clinical, leadership, education and research. So even though first contact practitioners have some of the domains signed off across the other 3 clinical pillars, they've got the clinical sign off, but they'd still need a top up to get to master's level on each of those. So once you're able to do that, you then move into advanced practice. So on this call today, we have Jo, who's going to be talking a little bit later, and she's on that journey already. She's already a trainee practitioner. She's going to talk to you about that later. What I'd like to do now, first of all, I'm going to hand you over to Jodie, who's a physiotherapist. Please, can you take this?
Thanks, Amanda. Yeah.
Please,
Thanks, Amanda. So hi all, and thanks for sticking with us late on into the day when I'm sure you're all desperate to be heading off home on a Saturday evening. So to introduce myself again, it's Jodie Smith. So I'm a MSK specialist physiotherapist, and I've worked in the NHS for 20 years. I've worked in the North, the Midlands and the South. And I think the fact that my career has easily enabled me to do this is something that I love about it. I've truly enjoyed working within differing demographics, learning from a variety of colleagues, and as important to me, I've met lots of friends along this journey as well. So I currently work for Somerset Foundation NHS Trust. I love that I can work in a portfolio role there, so meaning that I can use my knowledge and skills across more than one role. So I work as an MSK first contact practitioner in primary care and within spinal specialist clinics within a orthopaedic interface clinic. So knowledge of this entire pathway, work with the MSK pathway, working like this places me well, I believe, to be within these first contact roles, and that touches on what Amanda's just spoken to you about as well, about that breadth of knowledge and skills. I've worked at advanced practice level for the last 13 years, so I implemented a physio-led extended scope practitioner service as it was, so the sort of extended scope name predates the use of advanced practice. And that was in Birmingham, and at that time I also implemented a community-based, as it was then, joint physio and pain management service. The drivers for this were the Right Care Right Here drivers, and with this that was about obviously improving access to care closer to patients' home. So I guess it's no surprise then that when I relocated to Somerset, the chance to work within the first contact practitioner clinics in primary care and within a Vanguard project was an exciting opportunity. And now I work, as I say, within Somerset Foundation Trust, and we have a expanding FCP service within primary care, which is a county-wide host model. And Simon, who I know will be speaking after me, I'm sure will expand on this as well. He's worked in Somerset longer than I have, so I have lots to fill you in on there too. So finally, I think to add on to this year I've felt privileged that actually I've been able to work with the Health Education England Advanced Practice Primary Care Roadmap team. And with this, I've been able to be involved in the governance framework as well as co-authoring the MSK knowledge, skills and attributes. So what's great about this, as again Amanda's touched on, is that this is truly a multi-professional framework with a strong governance and quality assurance that is core. So to me that's important because it's about, in these primary care roles, being able to offer that easy access for patients, but being able to offer that expert care with the right clinician at the right time. So again, if we think about the MSK knowledge, skills and attributes, for example, if we look at how we've managed to achieve that quality assurance, we have, fortunately, the IFONT standards. That's the International Federation of Orthopaedic Manual Physiotherapy standards, but actually they're an internationally recognised standard which has been adopted by the World Health Organization. So we've used those as a benchmark, and we also have available the MSK Core Capabilities Framework. This obviously means then that the system has that assurance, and any professional working within these MSK first contact practitioner roles will have this standard as an absolute minimum. So I guess again, touching on or following on from what Amanda said, the fact that we're able to look at there being a generic core for these knowledge, skills and attributes, which we can then bolt on other specialities, subspecialty elements, means that these can then land in the system over the next 6 months. So, for example, we know that there will be one set out for paramedics. There'll be those set out for OT. So there will be more coming through. And again, there'll be other speakers today that will touch in on this. So I guess it just leaves me to say that the evolving multidisciplinary team within primary care, in my mind, makes primary care a fantastic and exciting place to be working at the moment.
That's great. Thank you, Jodie. Simon, would you like to take over from Jodie and let them know what you're up to in Somerset?
Absolutely, thanks, and good evening all. So I think just to introduce myself, I'm Simon Ingram. I'm a MSK physiotherapist too. I work as an advanced practitioner across MSK and also in primary care, as Jodie alluded to. My background into physiotherapy was a bit long-winded. It was my second degree, having enjoyed probably university too much the first time around. Then did my junior rotation, so got that kind of core kind of diversity that physiotherapy offers under my belt. And at that time, I probably never really appreciated how much that was going to help me further on in my career. So I've been working here in Somerset for 14 years. You may recognise the accent, so excuse the U's and the R's. But we have developed the team quite significantly over those years. And we now have, as Jodie alluded to, a portfolio of roles really spanning across not only primary care, but the emergency department and our orthopaedic clinics, both in intermediate and secondary care, which I work in. And for me, the variety that offers is what makes my job so rewarding, I think. So I think I'll just touch upon about what is it like to work as a first contact practitioner in primary care. I mean, I've been doing this for about 4 years, and I think the first thing I'd say is to acknowledge that it is challenging, and I think it pushes you to the edge of your knowledge, but every day is a learning day. And if you're of that ilk where you would like to continue learning and absorbing new skills and working within a multidisciplinary team, then there's no better place to be. I think there is a big team ethos, so whether that be the GPs that I work alongside, the nurse practitioners, or even the reception team, I think having us co-located in the practice is of great value and something that I've been able to learn a lot from. The role involves us seeing patients that are directly triaged from the reception team to us, so we kind of hopefully reduce the demand on the doctors within the practice. And there are times where there may be that uncertainty as to whether that patient is actually a musculoskeletal condition they're presenting with. And that's where, again, having those relationships with our peers is so important. And I think there is certainly a level of complexity that, again, coming back to what I said earlier, having done my other core rotations, I think I feel that I start to recognise when something may not be what I thought it was. And I can't emphasise the importance of that enough. Advanced practice also gives you skills to develop, and I'm a non-medical prescriber. I perform injection therapy, and we have the ability in our role to request investigation. So you're able to push kind of maybe what you see as the traditional physiotherapy role, but within that is very much still my core physio skills, which is about health promotion, exercise and rehabilitation, and that underpins everything we do. Here in Taunton, where I'm based in Taunton, the service started a number of years ago and has expanded, as Jodie said, with our colleagues who had other pilots across the county, and we are now one big team of just over 30 first contact physiotherapists. A clinic for us will last about 3 hours. We have 20-minute appointments, and very much we are one big team. And there is great value of that as well. Stepping out of primary care, we have that ability to share learning opportunities, but also lean on each other when we need to. And I think it's also important to acknowledge that resilience is important wherever we work. I think we all recognise that, and the complexity that comes with primary care requires that. So I think just to finish off, really, there's never been more exciting time to be involved in MSK physiotherapy. The work that Amanda, Jodie and the team have done with the roadmap, and all the opportunities and diversity it's bringing at the minute is a great place to be. And anyone who's considering going down that route, I couldn't encourage you enough.
That's great. Thank you so much, Simon. And moving on from Simon, I think it's timely now to bring Jo in, who's a podiatrist who is on the journey to advanced practice at the moment. So I think that this could be quite an interesting story for everybody. Thank you, Jo.
Hi, I'm Jo Hammond. I started off as a podiatrist at University of Huddersfield in 1994. Went through private practice whilst my children were young, and then into the NHS. Went into the health promotion side of it and became a team leader. I initially became interested in the advanced practice roles generally, speaking to some advanced practitioners who were working at a site that I worked at regularly. And eventually an opportunity came up. I was very fortunate with some people that I knew in the area who knew I was interested in it. So I was extremely fortunate in that respect. And I obtained a place at university to do the master's degree in advanced clinical practice alongside that to build on my competencies. The thing that I found particularly poignant was that there's a lot of transferability of the podiatry skills that can be extended and built on, because in advanced practice you can be pushing the boundaries of your knowledge, as somebody's already said, and extending beyond that. And you do draw a lot on the original training from your podiatry degree to move on into it. You know, the non-medical prescribing is part of the course, so you end up involved in that aspect. And transferability of the elements of the lower limb that you're dealing with, that you tend to pass on to primary care as a podiatrist. You start to become involved in dealing with those aspects, requesting investigations, doing the further onward treatment with lower limb conditions and beyond. It's extremely interesting. I absolutely love it. I wouldn't change it for the world. I've thoroughly enjoyed my entire career. I'm still a proud pod, even though I'm not in the completely traditional role. But at the end of the day, it is very worthwhile. It is very interesting, and every day is completely different, and you really learn a lot.
Thank you, Jo. That was a really lovely, passionate talk then. And if that hasn't encouraged people to do it, I don't know what's going to do that, really. So I'm going to hand over to Helen, who actually works with Jo, she's got a very interesting career pathway, because she's actually got two careers, two professions, allied health professions. But Helen's also been writing the knowledge, skills and attributes document ready for the podiatry roadmap that will be coming out in the new year. So I'm over to you, Helen.
Thank you, Amanda. My name's Helen. I'm a paramedic and I'm a podiatrist, and I'm very proud of both of my professional backgrounds. My NHS journey began in the ambulance service in 1993, and I worked my way up from the 999 control rooms, taking calls, through to being an ambulance technician, then to being a paramedic, and then I qualified as an emergency care practitioner. Within podiatry, I work in independent practice, but I'm able to combine both of my roles and skill set into my current role as an advanced practitioner within general practice. So when I completed my emergency care practitioner qualification, that gave me a taste of the other healthcare settings where paramedics could contribute to patient care. And this is where I first encountered general practice. So now I work, like I said, as an advanced practitioner in a specialist generalist role, rather than being an advanced paramedic or an advanced podiatrist. Within our practice, we're encouraged to do a lot of professional and clinical development into this specialist generalist role. So I work within a team of advanced practitioners, all at different stages within their training, and we're really quite fortunate because we've got a really great team with different professional backgrounds. So I ended up in my current role. I was fortunate enough to be part of Health Education England's 2016 Advanced Practitioner Pilot within general practice. Different counties looked at different areas where they wanted to develop the ACP role. And I was really lucky that I received HE funding to complete my master's degree in advanced clinical practice. And I was supported by a really incredible team of GPs to achieve these competencies. And obviously anybody else that's wanting to go down this route, have a look on your NHS jobs to see what apprenticeships are available for the ACP routes. So on a typical day, we work with clinical sessions where we see or speak to maybe 15, 20 patients per session, arranging any necessary investigations. Obviously, currently with COVID, we're bringing in the patients that need to be clinically seen. A lot of people we can follow up on the telephone, and we're doing a little bit of both video, telephone consultation and face-to-face. So I'm really lucky because I can combine both my paramedic and my podiatry background to enable me to help with all aspects of the patients that I do see. But then, for example, with my podiatry background, I did the master's module at Huddersfield looking at injection therapy, so I can help out in the minor surgery clinics as well, doing steroid injections. I'm an independent prescriber. I've actually put myself through that twice. I had to do it as a paramedic and I had to do it as a podiatrist. They wouldn't annotate both of my professional registrations with HCPC, so I did do that twice. I'm a big believer in holistic care, and I do always try and help with all that is needed with the patients that I see, and not just what their presenting complaint is in that day. I think that's particularly important in general practice, because obviously we're that hub that tries to coordinate all of the clinical needs for that patient. So in between my morning and afternoon sessions, I may go on home visits. Really quite lucky because obviously as a paramedic, going on home visits is one of my big comfort zones. Or it may be that with multidisciplinary team meetings that we attend, or we're participating in practice learning, that there is always something to do. You're never sat there twiddling your thumbs. Then also we action our own caseload of letters. Because we've requested pathology, we need to be able to interpret that when that comes back to the practice. And then one day a week as well, I act as the duty clinician, which is a similar role to the GPs when they used to do the duty doctor, but that's now been taken over by the advanced practitioner team, and we do have GP support there all the time in case we need it. But that's a really good and exciting, sometimes stressful day, but you never know what's going to happen. So that's what makes it good, because then each day is varied and you just don't know what you're going to be faced with. So moving from the ambulance service into general practice was a steep learning curve for me. And I think the key message that I would give anybody is just to remember really that barriers, they can be overcome, and the biggest thing that you can do to help yourself working or moving into another area from, like, for example, ambulance service into general practice, is just to remember hard work and determination will get you there. I don't believe there's any such thing as knowledge gaps. I see these as opportunities, and it's really key that we never stop learning.
Hello, everyone. I think, sorry about that. I think we dropped out for a while. I think the platform went down, but I'm glad we're all back. So if it's all right, I'm going to pick up the conversation. Just checking you're all in the right session. This is AHPs in primary care. My name is Genevieve Smythe, and I'm an occupational therapist, and I work at the Royal College of Occupational Therapists. And I've been involved in 2 pieces of work around occupational therapy in primary care. So the first piece of work was setting up and running occupational therapy-led vocational clinics in GP surgeries in Southampton and in South Pembrokeshire in Wales. I'm sure you're aware that lots of people go to GP surgeries for GP fit notes. In fact, 10 million people a year go to GP surgeries in England alone for GP fit notes. And we've been saying for some time that allied health professionals are actually in a much better position to be able to provide information to help people manage their health and work situation. So we just set up some clinics in GP surgeries, and essentially the people we were seeing were people who would normally turn up at a GP surgery for a GP fit note. So our occupational therapists saw those people instead of GPs. We did 2 things. We provided self-management advice for those patients about how they can manage their health conditions. And we spoke to them about what are the workplace modifications that could happen so they could manage their condition and stay in work. So it was a job retention project. It had really excellent results. We managed to reduce people's sickness absence time out of the workplace, and we managed to divert a fair number of people away from the GP, the GP sessions, because they were seen by the occupational therapists rather than the GPs. So I think as allied health professionals expand their roles in and around GP surgeries, it's something that all of us are probably going to start to do much more, because we've got really excellent skills about helping people manage their health conditions and think about how that applies to a work situation. The other piece of work that I'm doing is I'm chairing a piece of work on behalf of Health Education England, and we're writing the first advanced practice capability framework for occupational therapy in primary care. So I imagine it as building the prototype of an occupational therapist, an advanced practice occupational therapist in primary care. And to describe that role for you, that occupational therapy role is about seeing 3 particular patient groups. The first patient group is older adults, frail older adults, so that's usually people in their 90s and their 100s who are having problems managing in their homes, they're struggling to cope, they're becoming increasingly unwell, and they're at high risk of coming into hospital. And so we're working closely with other members of the primary care multidisciplinary team, particularly paramedics, going out and doing home visits. Paramedics are doing a lot of work around checking that that person is medically stable and doesn't need to be admitted to a hospital. And the occupational therapist is checking that that person is safe to stay at home in their home environment. Obviously, providing carer support is a big part of that work. The other group that we're working with in older adults is the 65 to 75-year-olds. So these are quite a different group of patients. I call them the well elderly group. So they're the group of people who are still active and independent. Quite often they're the carers for that older, frail older adult population. And quite often they come to the GP surgery with queries about how can they manage their long-term condition and still stay active and independent. So we're doing work around giving them advice and information about how they can maintain their roles and maintain their independence. The second group of patients that we're working with is people with mental health problems. Now, my background is in mental health. We're tending to see the patients who need more than improving access to psychological therapies. If you're familiar with that, that's 4 to 6 sessions of cognitive behavioural therapy that's available to people in primary care. We're finding there's a group of people who, although they benefit from that intervention, they need an additional type of mental health intervention. But what they don't need is they don't need referral onto secondary mental health services. So they don't need to see a psychiatrist. Predominantly, they don't need a medical intervention. So we're delivering interventions to that group of people. And then the third group is the group that I've just mentioned, and that's people who are coming to GP surgery with health and work problems, who would normally see a GP or a practice nurse for the GP footnote. So in the pilots that we've seen happening across the UK, some of those occupational therapists are doing all 3 of those jobs. So they're doing work around older adults, they're doing work around adults with mental health problems, and they're providing advice using the Allied Health Professionals Health and Work Report for employment support. However, as occupational therapists are expanding in primary care, we're seeing a new group of occupational therapists who are just being employed to do one of those types of roles. So we're just seeing some occupational therapists being employed in GP surgeries, and they're only working with older adults, particularly frail older adults. And in particular, some of them are just being employed to do work in and around care homes. As you can imagine, there's a high level of need working in around GP surgeries and in around care homes. The other new group of occupational therapists that we're seeing is particularly around this group around adults with mental health problems. And some of the most interesting new roles are actually around GP surgeries that serve particularly student populations. So if you can imagine, and it's in the news an awful lot at the minute, there's a lot of students at the minute who are experiencing a higher degree of mental health problems than normal. And we're seeing some occupational therapists moving into the GP surgeries that work in and around those student populations to provide mental health support so those students can stay in education and get through their degrees and manage their degrees. And then by the same token, we're just starting to have some interest in occupational therapists setting up work-related clinics. So they're not They're not doing the other bits of work. They're just about helping keep people stay in work. Now, the question you may be thinking at this point is, well, what is the difference? How does a GP know if I want an occupational therapist to do all of those things, or I want an occupational therapist to just do one of those things? And what we found from the pilots of occupational therapists and GP surgeries is this is driven by population need. So GP practices, one of the things I learned very, very quickly working in and around GP surgeries is GP practices and the populations, the patients that they see can be quite different, even in quite a small area. So if I think about the GP surgeries I worked in and around in Southampton, where we were running vocational clinics, we found one GP surgery was very, very quiet. When we looked at the population, it's because they had a lot of retired people who weren't in employment. So what we're starting to see is GPs, now they understand the wide range of things that occupational therapists can offer, they're starting to drill more into, well, what do we actually need for our local population? If I've got a big population of retired and older adults, we're going to need our occupational therapists to help more with older adults. If my population is more about working age adults, I'm more likely to need occupational therapists to help with the health and work situations that I was describing. So I hope that gives you a very quick introduction to our role. I would have loved to, I'm very, very passionate and excited about this area. It's the job I always wanted, so I'm really delighted that we're moving into these roles. If there's anything else you want to know about occupational therapy, this week is National Occupational Therapy Week. So if you get on Twitter and look at #ChooseOT, you'll find loads of information on our website about occupational therapy as a career and what you can do once you're already an occupational therapist. So I'm going to stop now and let one of my other colleagues speak.
Thanks, Genevieve.
Thanks.
Hello, my name is Ciara Tilley and I'm a speech and language therapist, and I started my career as an early years speech and language therapist working within community settings, and then subsequently I've moved on to roles managing both speech and language therapy and dietetic teams within both acute and community settings. Now that broad range of experience really prompted me to become really interested in thinking about where care was delivered and where patients would most benefit from being seen and by which professionals. Then I was lucky enough at the start of this year to move into a secondment with NHS England and Improvement, which was working as part of a team of 3 to write an implementation document for the recruitment of AHPs into first contact practitioner roles or advanced practitioner roles within primary care. And that felt like a real privilege and a fantastic time to really hear on a national level about all the great work that was going on in different areas of the country across different professions, and the work that and the impact all those projects that had been running had to benefit patient care, but also to really add to those primary care multidisciplinary teams. The document, I'm afraid, has been a casualty of COVID, so hasn't quite got published, but hopefully will be published soon. And that implementation document outlines just guidance for the recruitment of the roles that are being 100% funded as part of the GP contract. That includes dietetics, physio, OT, paramedics and podiatrists. There are other professions that subsequently they're going to be looking at, speech and language therapy being one of them. So the Royal College of Speech and Language Therapists is looking at how speech and language therapists can be used as advanced practitioners within primary care, both working with adults and with children. So that's a piece of ongoing work that's going on that hopefully we'll hear more about soon. The role I'm now in is I'm an AHP strategic lead with Frimley Integrated Care Systems. I'm just 3 days into that role, so it's still quite new. But within that role, I will be looking at where within the system and within primary care there are opportunities for us to expand those AHP roles and really work with our GP colleagues and look at where we can support, and completely in line with all the other speakers in those roles that they have been doing, and that they are aware of, is how we can use those within our integrated care systems to really truly benefit patients, to make sure that they're actually getting the right care at the right time and by the right professional. Thank you.
Thank you, Ciara. Hopefully everybody can hear me. Thank you. Can everybody hear me now? Yeah, oh great, thank you. Hi, sorry everybody, I've had a few major technical difficulties. So now, thank you very much for that, Ciara. Can we move on now to Lisa, who is going to talk us through dietitians in primary care? Thank you.
Thank you. My name is Lisa Ledger. I'm a dietitian and currently work at Royal Cornwall Hospital and currently professional leading dietetics there. So I started my career at Royal Cornwall Hospital 15 years ago. Back then it was a rotation post. In fact, we still have rotational posts down in Cornwall between both the acute and community settings. And that was fantastic. The rotational post gave me a really good idea into what areas I might like to specialise in. So I focused on community dietetics and moved to other trusts throughout my career, both in the north and south, before returning back to Cornwall again. Talking about health careers, I mean, speaking from a personal point of view, I've never been without work, which has been fantastic. I've been able to travel between jobs. I've had great flexibility with working when I had children. So, you know, as part of a health career in general, it's just a fantastic place or places to work. So to tell you a bit more about dietetics very briefly for those who aren't sure. So a dietitian is an expert in diet and nutrition, as the name suggests. We alter a patient's diet dependent on their medical condition or to support the medical treatment being given. So if you think of all the areas of the body that food and fluid pass through, you can imagine how many medical conditions that can relate to. So an example of some of the things that dietitians will do in maybe an acute setting, someone who's had a stroke, they often lose their ability to swallow, and will therefore tube feed that patient, and then will support their return to oral food with varying textures, while obviously making sure that their nutrition needs are met all the time. A patient with celiac disease, for example, they require a lifelong gluten-free diet, so we'll make sure we support them with that. Dietitians work in many areas, so we work with inpatients, as I've said, who are acutely ill. We cover lots of different specialities, so gastroenterology, renal, bariatric, oncology, diabetes, stroke, as I mentioned, tube feeding, pediatrics, parenteral nutrition, which is feeding into the veins. So I continue to work for secondary care, so hospitals, but recently we explored the role of the dietitian within primary care, so GP surgeries, as people have mentioned. So I was given 6 months of funding to look at a dietitian 1 day a week, and I chose to focus on looking at malnutrition with patients living at home. So malnutrition affects a huge amount of people, and especially as they age. So there's many things that happen as we age that can stop people eating as well. And many people often regard it as a natural way of getting older as well, which it's not. So malnutrition itself increases risk of death by 4 times. So it's a big area that dietetics can look at. It's got a huge effect on poor health outcomes, as I've said. Other studies that we looked into with regards to primary care, we looked at how we can treat paediatrics and take work off the GPs by seeing conditions such as milk allergy, reflux, eczema, faltering growth and constipation. The other study was to look at dietitians as first contact practitioners, as some of the other speakers have mentioned. So that's where the dietitian will see the patient straight from triage, so the GP appointment isn't required. The results of all the studies into dietitians within primary care showed significant GP and nurse time saved, as we had hoped. It showed significant reductions in medications required, such as nutrition supplements, antibiotics, bowel and reflux medication. it meant that the expert saw the patient right away rather than the GP having to refer on to a dietitian within secondary care. It also showed a much more proactive approach to healthcare and to keep patients at home in a healthier way for longer, basically ensuring that patients age well at home, which is obviously something that we need to be doing. Many primary care networks are now seeing that important role within their practice and are taking on dietitians in addition to other AHPs, if you've heard. That's fantastic as we try and keep those patients healthier at home. And from a personal level, working within primary care has been fantastic. I've been really welcomed and valued as part of their team. And I hope to continue working for both primary and secondary care at the same time. Thank you very much.
Hi there, I'll go next. My name's Andy Collen. I'm a consultant paramedic in the ambulance sector. I'm interesting compared to the others. I don't currently work in primary care, so my role is as a special advisor to Amanda's team, looking or helping to support the paramedic rotations into primary care, advising on role clarity and also the level of the different roles as they emerge. Paramedics are very much in demand in other sectors outside of the ambulance service, as Helen has explained. And we need to work across the whole system to make sure that both the ambulance sector isn't destabilised with the shift in workforce, but also we give paramedics the opportunity to practice across a wider range of settings, which of course is good for all concerned, not least patients. So that was a very quick introduction, conscious of time, and as someone who doesn't work in primary care, and we've had a really good overview of all the AHPs that are currently working in primary care. I will hope to hand back to Amanda if her connection will allow. So it looks like Helen isn't back. I'm not completely clear how we were going to cover the Q&A session. I believe there were some questions, but I'll ask one of the technical team to let us know. I suspect we'll have to bring the session to a close. So there has been a question, nice high-level one. So what is podiatry? There's some people that can answer that. Helen or...
I'll let you answer that, Jo.
Shall I go for this one, Helen? Right, so podiatry, it is neither children nor food, as we are often asked, if that's what it refers to. It's a lower limb specialist, essentially looking at medical conditions of the lower limb. There's the core work, which involves enucleating corns, removing hard skin, looking at those things that can cause quite significant pain to some people and can really make a difference to quality of life. Then the specialist services, the biomechanical assessment and the gait analysis, you know, how you walk can sort of really impact on foot conditions, so it's correct exercises and orthotics. There's the diabetic wound management and sort of high risk work dealing with vascular patients, a bit of nail surgery. One thing I can say, it is not just cutting toenails.
Absolutely, thanks, Jo. As paramedics, we learned a huge amount about podiatry as we followed you through the independent prescribing journey, which is really valuable. And there's something about advocating for all about each other's professions within the AHP family. I've certainly found that over the last 10 years as I supported the independent prescribing project from our perspective, which I think adds an additional dimension to what we do as AHPs as a wider team. And that really is evidenced through the work that's going on in primary care, which I think is a really good place to finish the session on, with a celebratory note. So thank you for listening, and we'll bid you good night.